Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. I would like to officially open the seventh of our 2025 sessions in our Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I would like to begin today with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Takaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. It is now my great pleasure to introduce Misha Richard. Misha Richard is the Emergency Preparedness Lead at Thunder Bay Regional Health Science Center and facilitator for the CFL York TBRHSC series and will be moderating the panel or the discussion for today. For the sake of time, Misha's full bio and the full bio of all of today's speakers will be shared in the chat. Misha, thank you very much for moderating today's session and your ongoing help in putting the series together. The floor is yours.
Lovely. Hello, everybody, and welcome back. I'll start off by just doing my little housekeeping reminder quickly that we have a chat. It is available for you to populate with all of your questions and dialogue amongst yourselves. But if you have questions for today's speakers, we encourage you to put those directly into our Q&A. I'll be monitoring that throughout, and I'll put those questions to our speakers at the end of the session. So without further ado, I will introduce the two gentlemen that we have with us today all the way from the West Coast. So I'll start with Scott. Scott is a fire and emergency management professional who's worked with the British Columbia Lower Mainland Health Authorities for 19 years. His career has spanned a range of health services from large tertiary to remote community hospitals, long-term care facilities, community programs, and public health. Presently, Scott serves as the Health Emergency Management BC, or HEMBC, Senior Director for the Lower Mainland team, covering Vancouver Coastal Health, Providence Health, and Fraser Health Authorities. I did want to note here for everybody's awareness, we have some additional information about HEMBC and Scott's bio put into the chat there, but they're responsible for providing emergency management leadership and support to the BC Health Authorities. And then with us today, we also have Craig Brown. So Craig is a senior scientist of climate change and health at Vancouver Coastal Health Authority. He supports climate action and health protection in communities that are exposed to a range of climate-related hazards, and also teaches about climate risk management at the University of Victoria and Royal Roads University. So thank you to both of those gentlemen. Again, full bios are in the chat. And I'll turn it over to Scott, who's going to get us started. Perfect. We can see your screen.
Okay. Thanks, Misha. Good morning, everyone. Happy to be joining you from the wet coast of British Columbia with my good colleague Craig this morning. And to start us off in a good way, recognizing that we're joining you from the traditional, ancestral, and unceded territories of the Coast Salish and Inklipamuk nations who've cared for and nurtured the lands and waters around us since time immemorial. And in particular, I'd like to recognize that I'm joining you today from the lands of specifically the Kwantlen, Matsqui, and Katzie First Nations and the chosen home of the Surrey Delta Métis Association. Going to provide a little bit of background for those who aren't familiar with British Columbia's health system, because it does have direct implications to how we work in the heat space. So British Columbia is broken into 5 regional health authorities, and within those health authorities, those leadership groups cover the entirety of the public health system. So everything from acute long-term care, primary care, population public health, mental health and addictions, all of these programs fall under a singular body within the health authorities. Our particular program, though, is one of the misfit toys that fall under the Provincial Health Services Authority, which essentially has all of the provincial agencies under its banner that include things like renal, BC Cancer, and others. And our particular group, Health Emergency Management BC, provides the emergency management supports to all of the health authorities throughout the province. And our primary focus there being the management and support of the public health system, but additionally the liaison function with many of our external partners. So we work with many different organizations throughout the province. And with respect to our particular team, we work with two health authorities here in the Lower Mainland. So we're lucky to have the opportunity to be able to work in Vancouver Coastal Health and Fraser Health, the two largest health authorities in the province, comprising about 60% of British Columbia's population in this small bottom left-hand corner of your screen, just beside the island. So jumping right into today's topic, for those who might not be as familiar with heat, happy to kind of give a little bit of lay of the land. And I'll maybe explain that I was pulled into heat planning back in 2014, and I'll give some history to that a little bit later on, but I was wholly ignorant to the scope of how large and catastrophic this particular type of weather event can be on human population. So we recognize today that it is the most dangerous weather-related disaster that can and does occur. Although most of us, I think, immediately go to the ones that have far more obvious economic and health impacts, flooding, hurricanes, etc., that have a very visceral feel to them. Heat is often referred to as an invisible threat because many of the deaths related to it are not obvious. They occur over a span of time. Individuals die in their homes or in hospitals due to other conditions that might not be flagged initially as having been exacerbated by heat. So from the WHO, we know that almost 500,000 people die globally every year, at least between 2000 and 2019, estimated. And in last year, in 2024, the UN Secretary General issued a call for action on extreme heat response with respect to not only the existing deadly impacts of heat, but also the recognized increase in temperatures as the climate crisis continues. So when we talk about extreme heat, just some background on that. One of the things that we know is that the mortality rates increase as heat increases. So that's one of the primary and most devastating factors of heat, but we also see other aspects of it. So the morbidity rates, or the number of people who get sick during extreme heat events, increases during these periods. And it's quite notable that it is the indoor temperatures that are the danger here, which is often different from some of the other types of weather events that we experience in the winter, for example, where extreme cold is more of a concern for those who are experiencing homelessness. In this circumstance, it's more of individuals who have homes but are not protected by air conditioning systems, etc. Additionally, it has impacts to the mental health and well-being, and recognize that part of that is a reflection of the mental health and well-being of those who work in the health system, as we often see surges and increases in the acuity of the patients that we see, the clients that we visit in homes, the residents that we care for in long-term care facilities. And maybe to table set for those who might not be familiar with Vancouver, this is not an unusual view from our windows for a good portion of our year. Vancouver is known to be a very mild climate, and as a result of that, it is not well prepared for extreme heat. In fact, I think the last census in Vancouver area was about 26% of all homes have air-conditioned systems in them. And that plays a huge factor in how extreme heat has impacted us in the Lower Mainland. It's notable also that when we talk about temperatures, the human population and the adaptation that occurs is really a reflection of the types of temperatures that we're used to. And as a consequence, our particular corner of British Columbia is not used to very high heats. Now, a little bit of a bait and switch here in that we said we were going to talk about 2021, but I really can't talk about the heat dome without going back to 2009. This was a pivotal event for us in British Columbia in that our southwest corner, here where the 60% of the population lives, experienced an 8-day heat event from July 27th to August 3rd. And I want to highlight the timing on this. This is right at peak summer period. So we've already had a month of warm weather in July. People have some adaptation at this point to the heat. But even still, this was remarkable for the temperatures that we would normally experience in this period of time. And the length of time is a significant factor in how that played out for us in terms of health impacts. The kind of temperature gauge that we use in Vancouver truly isn't Vancouver. Don't pass this on. It's actually in Richmond at the Vancouver airport. And during this particular event, it reached a peak temperature that we had not experienced previously and actually have not beaten since, of 34.4 degrees. And a significant portion of that is we live right at the edge of the ocean, and we often get breezes that come in and cool the population. And during this particular event, that didn't occur. So the cooling that we normally experience just wasn't there. But the most notable thing about 2009 is that it was well recognized after the fact. But during the event, we did not see significant impacts to the health system such that it required us to stand up emergency operations centers, et cetera. So you can basically describe it as we had some bad days at our emergency departments. It was busy times, but it wasn't such that we were waving the flags of things have gotten really bad. Having said that, we had some and continue to have some amazing work within the BC Centre for Disease Control in British Columbia. Amazing researchers in Tom Kasatsky, who's now retired, but Sarah Henderson in particular, who I put her image here, as I would suggest one of the major champions in British Columbia, ensuring that heat is well understood and supporting our public health representatives and the health authorities with real information, data, and expertise to support adaptation and understanding of the dangers of extreme heat. And it is in their great work that I put an image here on the right-hand side that created some visibility around what really was not visible. And that is, if you take a look at the screen here, you see that there's a peak right around week 9 and 10. And that peak is demonstrating the maximum temperatures that we experienced during that heat event. And the bar graph underneath shows the mortality rate, so the number of people who die. And the horizontal dotted line there represents the mean deaths per summer for a period of about 5 years previous. So that's where you see the median line, and you'll note that there was a significant increase in deaths during that particular event. And why that's so important is that those deaths weren't marked as a building has collapsed, a flood has occurred, and people have died in the streets. These represent individual deaths that cumulatively are beyond what we would normally see. And it was from their great works that we had a visualization of the impacts of these extreme heat events. And as a result of that, there was the recognition that there were more people who died than should have, and there was opportunity for us to be able to prevent some of these deaths from occurring, or many of these deaths from occurring. It's interesting that when I was brought in 2014, I was asked to help support then a developing alert system that they were proposing to put in place. And I had the opportunity to take a look at the list of excess deaths. And I thought, here it is, the smoking gun to demonstrate that extreme heat is very noticeably and very clearly a danger. And as I looked through the list, there was only one listed death that showed hyperthermia, so essentially death by exposure to too much heat. The rest of them weren't obvious deaths. And so again, it reflects this concept and idea that the heat events are often missed as a risk within our communities. And through their work, we managed to kickstart the heat response planning in our region as a result of this great work. But I'll say that it would only have gone so far were it not for that one death that was listed as hyperthermia. And it really speaks to the importance of the community and the specific standing up of our community around this particular death. So the image there is Curtis Brick. He's an Indigenous man who was experiencing homelessness. He was in a park on the hottest day of the 8-day period. And Curtis was spotted early in the morning, lying asleep in the park. And many hours later, same individual came by and saw him there, but at this point he was now convulsing. And while he was in this park, there was many people there. There was no one who had approached him. And when the first responders came, there were many witnesses who said they did not feel that his treatment was reflective of what would have been expected. And unfortunately, Curtis died in the hospital later that evening. And he probably would have been missed, and this singular death would not have been noted were it not for the fact that the community came together to push for change. And one of those, the Indigenous Action Movement, in addition to the Union of BC Indians Chiefs, Aboriginal Transformative Justice Services Society, BC Civil Liberties Association, and many others came together to push for a coroner's investigation into Curtis's death. And it was through this great works that the city of Vancouver started its own program to address extreme heat and other types of weather emergency services for those who are experiencing homelessness and other vulnerable populations. And truly, it was the city of Vancouver that started in our province a real effort to make plans to address the risks associated with heat. So it's notable that for an event that's usually invisible, Curtis's death was one that spoke on behalf of the many people who had died in that kind of invisible way of not being linked to heat. And it is the great work, again, of the community that came together to push for change in this space, for equity and for inclusion and recognition of those who are at risk, that really changed the landscape for us in the Lower Mainland. So we started with a heat alert and response system in the Lower Mainland the year after that heat event, as BC CDC came out with their studies that demonstrated that there was real risk here, to help encourage our local governments and other agencies to start to work towards a process of heat response. We tied this to the temperature levels that we saw in 2009, and it was a two-stage process, one that had a lower heat warning level that essentially was a reflection of an increase in the mortality rate of 5%. And that heat warning level we expected to occur about 1 to 3 times a year. So a more common event, but one that we wanted to ensure had public recognition and that there were opportunities for local governments, et cetera, to establish proactive and systems such as opening up cooling centers. But what was really important for us is to ensure that that extreme heat one, the one that we experienced in 2009, was recognized as an extreme heat level that required action that was beyond the kind of standard one we would see from year to year. So this was established and shortly after 2010, and it became our touch point as throughout the next almost 10 years, as it went through some iterations. And some of you who might be familiar with the push from Environment Climate Change Canada and Health Canada in around 2018, I want to say, don't quote me, where we saw a HARS process rolled out across Canada, We did retain our two-stage process though during this time. So we had the heat warning level established by Environment Climate Change Canada and Health Canada as informed by BC CDC and British Columbia's health system. But we also retained that higher level alert process. And so that's what was in place as we rolled into 2021, where we experienced a weather event that was unprecedented for our region and was, by the specialist accounts, a 1 in 1,000 year event. So for 8 days, and here's a really notable point. This is now June 25th, so a month earlier than our 2009 experience. So already putting us at a point in which the population did not have as much adaptation as we had seen in 2009. And most notably, this heat event occurred not just in the southwest region, but throughout the entirety of the province. We triggered the heat warning levels in all regions. And in several of those regions, we were exceeding our historic records by of 5 degrees. So an incredibly powerful extreme heat event. Ultimately, over time, the BC Coroner Service managed to review and identify 619 heat-related deaths associated with this event. It also caused some serious impacts to the health system that required very urgent action on the part of the health authorities and our teams to respond. And I do want to put this particular slide up because, again, BC CDC's great work in making the deaths related to heat more visible demonstrated that we again saw the excess mortality rates during this period. And of course, the numbers that we saw in the excess were higher than those identified by the coroners. In the coroner's review were distinct and directed linkage between heat, etc. But we did still see excess deaths over and above those identified by the coroner's office. And the other element that I want to point out here is you'll note that the peak temperature here, the blue line on the upper section, and then our vertical dotted line here demonstrate that the excess mortality, so the death rate, continued the day after the highest temperature in which we noted. So it's important to take away here that just because the temperature starts coming down does not reflect a reduction in the potential and impacts in our community itself. And what were we seeing out in the community? This is some great work that was pulled together for the extreme heat and human mortality death report from the BC coroners, and many partners from health system came together. And this particular one demonstrates the temperatures that occur within a home that does not have air conditioning, so the red line there. You'll note that as temperatures increase, so we have our outdoor temperatures in black. As the outdoor temperatures increase, you'll see that large gap between the peak temperature and then the cooling temperature overnight. But the homes do not cool as significantly as the outdoor does. And as a result, you'll see that the red line continues on an angle upwards. In other words, day over day, it's increasing in heat in those homes, which is why we're starting to see temperatures that are reaching dangerous levels. And that is why we saw both an increase in those who are sick from heat, but also the mortality rates that we saw as well. And notable to put in that air conditioning line below that shows if you're in a home with air conditioning, you have the maintenance of that temperature range. Again, for us here in Vancouver area, 26% of whom have air conditioning, a significant portion of the population does not and did not during this heat event. So a quick review of what we experienced. The first element and most notable was the ambulance system was completely overwhelmed. We did not have the response times that we would generally have from our ambulance service. They were, in some cases, delayed significant points of time, and in some circumstances were not even able to attend some of the calls that were experienced. Most notably within our health system, we were triggered our emergency operations centers. We'd already stood up and had put messaging out to the community that our extreme temperatures were being met on the Friday. The challenge is being it was Friday. As many of us in emergency management know, that's where we get up most of our disasters. So messaging went out to partners very late in the day, although they had been given a heads up by Environment Climate Change Canada much earlier in the week, and we had provided a heads up that it was likely it would trigger our extreme heat levels. It was still challenging for everyone to receive that near the end of the day. Also on a busy news day where the COVID measures in the province were being announced as having stepping down. All of these things created some challenge in ensuring that the population was aware of the circumstances leading into the weekend. So on the weekend, on the Sunday morning, that was the alerts went out on Friday. So by Sunday morning, those temperatures indoors were becoming quite dangerous, and the health authorities in Fraser Health were receiving calls from long-term care providers indicating that their cooling systems were not functioning adequately, and there was now exposure to their residents of very high temperatures in excess of 34 degrees. In our emerge departments, while we saw an increase in general emerge visits, that was not the particular challenge that occurred. It was around the severity of the illnesses that people were experiencing, and I'll speak to that in more depth in a moment. So as a result of the long-term care facilities requiring assistance, we did stand up both local and our regional emergency operations centers. And as these things happen, of course, I was not there. I was on vacation, as was two of our public health leads in Vancouver Coastal Health and Fraser Health, who were the ones working in this space most frequently. Again, a good example of why you ensure your plans can work for when you're not there. Those regional EOC stood up, and with the great work of many of my MBC team and the management team that I still work with today, were involved in that, including reaching out to providers of cooling systems, air conditioning units, et cetera, and having them dispatched to long-term care facilities to support their cooling. We knew that from our home health and home support programs, which on the Monday when we started up our regional calls, started to report that they had clients in unsafe temperature conditions, and in some circumstances did encounter clients who had passed away in between their visits. That, of course, put a significant stress on our morgue capacity across the region, and some of our external expansion of our morgue systems involve trucks and systems of that nature, one of which had a failure of the cooling system in it as well. So it put a stressor on the facilities, and not just our morgue units, but also the buildings themselves, because many of us have Frankenstein buildings that have a variety of ages going back some more than 50 years. Up to our more recent one. And so many of our buildings just weren't capable of cooling adequately in our regions. That not only caused us to have to bring in temporary systems. I think one of our hospitals probably bought upwards of 50 fans. But we also saw that impacting things like surgery, where the temperature and humidity caused some of their environments not to be suitable for use. So mindful of the time, I'm going to breeze through a couple other points here quickly that probably better visualize. So this on the top here in yellow is events where we see ambulance dispatch, and you can see that it's normally around the 90 percentile. But during the peak of the heat event here on the June 28th and 29th, we saw that dip well below that by, down into the 70 percentile region almost. So a significant challenge in ensuring that our ambulances were being sent to those who were sick. But you also see in the red bar graph here that the 911 calls increased significantly over this period of time. So we have this crush of 911 calls, we have ambulances that aren't able to attend those, and we have a significant delay in even the dispatch element of this work. That paid a particular point with some of our local governments who fire departments are responding to these calls and how they in turn had their own crisis of management of heat-related illness calls. I mentioned earlier around the ED visits. So the upper bar graph, or the upper graph here, sorry, you'll see the first grade section. That is our heat dome of that year, but there were two other heat events later in the year. You'll note that the black line here represents our ED visits, the total numbers that we experienced for per day. And you'll see that there was definitely a peak around the 29th there, but it's not dissimilar than peaks later in the summer as well. But if we look at the lower graph, this is where the telling part of this extreme heat event was. The red line down below is our CTAS-1. So that's the Canadian Triage and Acuity Scale that we use here in British Columbia to determine how sick someone is. A CTAS-1 is a very sick person. They require the most amount of resources, both in terms of human and medical attention, but also the supplies and supports that you would need for them. It also reflects the length of time that that individual is going to be in our hospitals. So we saw a significant surge of CTAS-1, so 5 times our average earlier in that month of June. And additionally, the CTAS-2s, we saw an increase of 1.2% times, reflective of a very significant number of people coming in with that high acuity levels. This had extreme pressure on our emerge departments and required coordination on the level that should have prompted consideration for standing up our emergency operations centers and a higher level. But it's notable that unlike a weather event that often has a singular acute trigger point, this one was an accumulative effect, essentially being like a frog in a pot. And when you turn up that heat, it does not know to get out and it starts to boil. We experienced this similar type of scenario where these groups of people started coming in over a period of time. It's difficult to sense it in the same way we would where we get a call that a mass casualty incident has occurred, and we start immediately into our plans to manage those numbers. I do want to speak specifically to this before I hand it over to Craig, though. One of the outcomes of that, of our fire departments in City of New West, which experienced the highest death rate by per capita in the province during this event, they have a collaborative program with the fire department, the City of New Westminster, and the Fraser Health Authority. Their plan is during extreme heat emergencies to stand up this emergency monitoring center where lower acuity 911 calls will be redirecting those patients to this facility where home health and fire department staff will help to cool and monitor those individuals during that time. So this is one of the innovative ways in which we've managed to introduce a means to reduce emerge surging during heat events. And the final point I want to make, and one of the biggest legacies that we have as a result of this was the stand-up of seasonal readiness committees in Vancouver Coastal Health and Fraser Health. So these committees were initially stood up to focus on heat planning, but have expanded into other types of seasonal events, especially recognizing that in 2021, we had very large wildfire season, but we also had atmospheric rivers that resulted in major flooding in our lower mainland and other parts of the province. So as a result, we've brought together operational leads from the entirety of the health system under the health authority, so acute long-term care, primary care, renal, priority vulnerable populations, our public health, home health, home support, and mental health and substance use together, and to plan in these particular areas to discuss how various types of seasonal hazards may impact the health system, and to help to develop plans that are specific for each of the operational groups to address the likely impacts to their specific programs. So out of the 19 years that I've been working in this area, I have to say that this is the one that has been the most encouraging for me, as we've seen real proactive efforts to ensure that we identify impacts and to have plans in place to work through them. Okay, I'll just share that the last element of that, and the first thing we did again was to develop our heat and smoke plans for across the entirety of our organizations. And at this point, I'm going to hand it over to my colleague Craig.
All right, there I am. Thank you, Scott. Hopefully everything is okay on my end. For those of you that saw, I disappeared briefly. Zoom just misbehaving, so the adrenaline is slowly draining from my body, but we'll just cross our fingers. So, Scott, it's awesome to hear you talk about all of the background that's gone into all of this work, and just picking up on the last piece, the Seasonal Readiness Steering Committee work from inside Vancouver Coastal Health, which is where I sit in public health. Uh, just watching the explosion of activity facilitated by Health Emergency Management BC with leaders from all across the various health service areas within Vancouver Coastal Health to make these heat and smoke plans in very short order. It just showed a tremendous amount of political will that yes, it took Canada's deadliest extreme weather event to unlock, and that's kind of how it happens sometimes. And in a similar way, just to kind of segue to the public health realm for a moment, which is what I'll speak about for the next 10 minutes or so, is just the report to the chief coroner of British Columbia following the 2021 heat dome really gave us in public health and across the health system in BC a tremendous amount of, I guess, an impetus for the work. It gave legitimacy to the work. It unlocked a lot of political will and resources. And, in brief, this report had 14 recommendations across three areas. And I'm going to speak to the first two primarily, but I will touch on the third one as well. It Again, it's like you wait for these events. Scott longer than me, but I was in my role as a climate and health lead for a couple of years before the heat dome, and it was night and day. I mean, it really did wake everybody up to how impactful heat could be in British Columbia and what it meant, especially within public health for folks' ability to stay safe in their homes. So the first action there is to create the provincial heat alert response system. And Scott kind of touched on that we had one before the heat zone, but it really, following the heat zone, the BC HARS, as we call it, the heat alert response system, became much more, official, capable, important. And like the example that somebody dropped into the chat from Ontario, it's got a variety of criteria for these two alerting levels. We won't go into all of that, and that's evolving anyways, likely for those of you in Ontario as well as Environment Climate Change Canada transitions to a risk tiered alerting system with yellow, orange, and red instead of our two-tier heat warning and extreme heat emergency system. But just to briefly describe it again from the public health dimension, this is not a prescriptive set of recommendations that go out to our partners in local governments, etc. But it is, again, it was a really exhaustive list of things that you could and should and ought to do to get ready for the heat season and to respond during heat events for a variety of actors created by a variety of experts. And it filled that vacuum where we knew we needed a coordinated response system. The powers that be at the provincial level, et cetera, hadn't quite made that a reality. So this is what the folks in BC came up with. And Scott touched on this, but it came again from a set of kind of internal champions who took the reins, Scott included in MBC, but especially a shout out to Sarah Henderson from BC CDC. If those of you who have seen Sarah speak, she's a real dynamo out here, has been committed to this cause for a long, long time, and serves as one of the leaders that brought BC Heat together, the BC Health Effects of Anomalous Temperatures Committee, coordinating committee. We love acronyms. I suppose we love them less now that ChatGPT can just make acronyms for everything. But back then, back in 2022, acronyms were still special. And again, the key message here is just that this group of individuals from a variety of organizations was it filled this void. We needed a committee to, one example is determining an extreme heat emergency. Yes, there are a set of criteria, but it's up to those medical health officers, you call them medical officers of health in Ontario, and others with that line of sight to the health effects and with the legislated mandate of a medical health officer to determine when that emergency is going to be set in place and when it's going to be stood down. And so BC Heat does a lot of things. It does things operationally. It does a lot of advanced planning. There's much more information on that that's available and that I can share or Scott can share after the presentation. On to the second recommendation from the BC Coroner's report, ensuring that vulnerable populations are identified and supported. What I've got here is a graphic, an infographic from the 2023 Chief Medical Health Officer report from Vancouver Coastal Health, and I'll drop a link into the chat when I'm not presenting. But how do we know who we ought to be protecting? There's a lot of intuition here. A lot of folks might have a different strategy. First thing we did is just kind of try to get a sense demographically of what the various populations that need looked like in our health authority. We approached this question quantitatively as well. So we've got a map here showing where those emergency department visits originated during the heat dome. This gives you a sense of in your community, where should you be focusing your efforts? And again, Vancouver Coastal Health, one of 5 regional health authorities in British Columbia, we serve a huge geographic area, including up to the Central Coast in British Columbia here, but up to Whistler and Squamish and Vancouver, Richmond, the North Shore. So trying to get that quantitative insight into where did these ED visits originate. No surprise, it's from our dense urban areas, but all of the demographics from the previous slide come into play to inform this as well. And again, this is all part of us trying to answer how should we prioritize our activities in public health and across the health system to serve those who most need it. A piece that I find particularly inspiring, and again, this is all described in our 2023 Chief Medical Health Officer report on climate change and health. This is a survey that the BC Centre for Disease Control, Vancouver Coastal Health, and the City of Vancouver did. Hundreds of respondents with the ability to monitor indoor temperatures, and during several heat events would upload that information along with their experience to a database, and that was analyzed. We have a greater understanding of what indoor conditions look like during hot weather. We know that it's indoor temperatures that are the big killer here, and so having that insight again is just a really important piece to figure out how we can prioritize our work. And in brief, the findings from that are summarized here in this infographic. Again, it's not none of this is rocket science, but it is important to have these insights generated from your local conditions and for a specific community. So we knew that folks who were on the top floor, folks with units who were facing south and west, etc., they were the most at risk during those heat events. They experienced the highest temperatures. And those obviously with trees around their building, facing north or east, and with the air conditioner or heat pump were highly protected during those events. So again, a survey like that, it seems somewhat rudimentary, but it provides a level of insight that we just don't have. The million-dollar question out here is how many homes have air conditioning, for example. In public health, we view air conditioning in somebody's home as a health protective measure. There's no great way to determine that. It's even difficult to figure out how many heat pumps have been installed in the last 10 years, and especially difficult in multi-unit residential buildings where most of the folks who experience a higher risk during heat events live. So again, this survey gave us some insight into that. We have a very simple graph here that shows, under 40% of folks reporting that they had an air conditioner or heat pump. So that gives us something to look at. But again, this is more philosophical, and I'm smiling because it's any of this work we do a snapshot, right? This survey, all this great data, forms a snapshot at the time of what things looked like. We had this many homes that were overheating. We had this many folks with air conditioning, and this landscape has changed. I'm going to describe that now because through some work that came out of the University of Ottawa that was amplified by the BC Centre for Disease Control, we knew now that it was 26 was being treated as this magic number, above which the folks who experienced higher risk during heat events were really at peril. and over 31 degrees posed a risk for basically everybody. And it gave us these two temperature thresholds to then advise our advocacy work. One of those pieces of advocacy was we need more active cooling in people's homes. That's just again, the hundreds of deaths that occurred during the 2021 heat dome, the majority of which were in people's homes, and the majority of which would have been prevented had there been an operational air conditioner in the home. So in British Columbia, this decision is even a little easier because we have such low carbon intensity in our electricity grid. It's not perfect, but it's fairly clean electricity, so we can bypass the concerns about exacerbating climate change with this largely. But what has happened since is there's been a tremendous amount of evolution. There's been, you know, can landlords push back on tenants' requests to install these heating? Can strata councils and condo boards push back on window units or excess air electricity use from the portable units that sit on the floor? All of this was swirling for at least a year following the heat dome, and BC Hydro, and again, this is a interesting example of political will unlocking a tremendous amount of of excellent action. Is the Ministry of Health here worked with BC Hydro to release basically over the course of 2.5 years, $32 million to install, provide and install air conditioners for those who needed them. There was an income qualification. There were other pathways where a home health nurse, for example, could refer a patient. There were multiple pathways by which people could get these into their homes for free. And again, on this slide, we have 22,500 units distributed. And the next slide is an infographic from BC Hydro just showing the same number, but along with that spend of 32 million. And this was something, again, kind of like Scott and I would have spent, and all of our colleagues spent years, you know, shouting that this was a really important thing to do before 2021. And then all of a sudden you've got the seasonal ready steering committee. And the same thing happened here where, you know, for years and years, you knew this was an urgent public health priority. But once the political will is unlocked, great things can happen. So there's a lesson there about how to change the world. And I'm not sure it's a great one because it sometimes feels arbitrary that these decisions just somebody has that aha moment and there we go. So I'm going to end with one last slide that is really about that long-term piece, which is, okay, the air conditioners are great. They're of course a Band-Aid, but they're a really effective Band-Aid. But what we need is buildings that are designed to operate in a way that protects people's health. And this largely falls under what we call the right to cool. This is where we in public health do a lot of our work, even now, with all of the air conditioners that are out in the world. And just an example is, you know, the city of Vancouver now requires mechanical cooling for all new multifamily buildings. That started in January 2025. This is something that we advocated for. Our BC building code now requires that new homes have at least one space, for example, a bedroom that doesn't exceed 26 degrees in the hottest design temperature. Again, there's all sorts of enforcement questions here. We haven't figured it out, but getting these regulations in place was really important as a first step. And finally, there's a report I'm going to share afterwards. The existing buildings are obviously much harder to achieve that climate resilience within. And so our Zero Emissions Climate Ready Buildings project identified 31 recommendations. We were able to co-fund that and lead that with the City of North Vancouver and with others. It's a great piece of work. I think the findings would apply out to Ontario and other jurisdictions as well. There's a million other resources I could talk about. These are all on our website, vch.ca/heat. And I just want to stop now so that we have some time for questions. And thank you for your attention.
Awesome. Okay. I was going to say this is such a dense presentation. There's so much information that's coming at us. And I recognize that folks that have been following the chat, some resources and links have been dropped in there. And when this recording becomes available online, and we share that on our social medias. We can include some of these links there for your reference as well. So I find this really interesting to talk about because, as you said, Scott, this is invisible. You don't have debris that you have to clean up afterwards. You don't have to, do mass evacuations and things like that have these big visual cues. And so it does kind of sneak under the radar for so many of us. One thing that I thought was quite interesting is, you've made all these references to your alerting system. But I think this ties back to that many of us that work in healthcare don't have a formal process to monitor weather and temperatures. You may react to receiving an alert saying that there's, a warning that's taking place in your community. But prior to that, we go into these kind of seasonal fluxes, and we might be missing that built-in procedure to stay on top of this. And I don't know what that looks like in your organizations. You've created the alerting system, but who's responsible for actually taking that information and running with it in a hospital, in a long-term care home?
Yeah, I'm happy to speak to that. So within our Lower Mainland team, whenever there is a weather alert of significance, so we have wind thresholds, for example, after 90 kilometers an hour sustained, we know that there is going to be impacts. Our team sends out messaging to, in some cases, distribution lists to leadership throughout an entire health authority. In other cases, it might be directed to specific on-calls within a particular region. So we have developed our own internal messaging system where we take external alerts and then essentially we interpret them for our health representatives. And I think to your point, Misha, it's important because we encourage many of our health representatives to sign up for EC Alert, for example. But context means everything. When we get an alert that there's an atmospheric river coming, it's going to be a lot of rain. That's one thing. But when we get an alert that we're receiving, a month's worth of rain within 2 days that we did later in 2021, that is contextually something that says, oh, we should probably be paying attention to this particular problem. So I think to your point, it's important that there is an internal evaluation for the health system to be able to determine and stress that, hey, this is unusual. For us, for example, the fact that this moved from, I will say, since 2009, and even then, again, it wasn't that notable within the health system. There weren't people going, wow, 2009, remember that day when we had that huge surge? That didn't happen. We didn't experience that level of like, my gosh, this is very dangerous in the same way that you do when there's a major weather event. So as a result of 11 years thereafter, we had a bunch of people who weren't paying that much attention to heat. Oh, it's another heat warning that's come out, and we see an increase in heat-related illnesses, but nothing significant. So as a result, we become complacent, as we do as human beings. And, it is our ability to, as subject matter experts, to be able to interpret, to say, whoa, 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 hold on. This event is going to be more impactful than the last 10 or 11 years that we've experienced before. We're lucky and blessed that our team is able to do that here with our Lower Mainland health authorities. But to your point, not necessarily all organizations have the ability to do so.
Well, since you mentioned the atmospheric river also happened, I know somebody in the chat was talking about that summer and was working out in your jurisdiction and was saying, okay, we had the heat, we had the wildfires, we had the atmospheric river, then we had more heat. And so I think it really highlights, obviously, that hazards don't take turns. We get hammered by things simultaneously, pardon me. And you had mentioned, obviously, in 2021 with the heat dome, that was still overlapping with a lot of the COVID concerns, which makes me think about staffing questions as well. As I want to encourage everybody to put their questions in the chat. I think a couple have come through, so I'll defer to what's been populated in a moment. But is kind of this staff consideration, because we're seeing this as a whole of community approach. Certainly anything to help alleviate pressure on the emergency departments or on our paramedics and first responder teams, to have members of the community be more safe. But I'm curious about staff considerations, if you had changes in staffing during those times, if there's any numbers on that. Certainly because, you know, is somebody choosing to work from home because it's cooler in their home versus in their work environment in a healthcare setting? Or are they having to actually take time off because they're now checking in on family members or things like that while this is going on? So curious about staffing. And then also you said Frankenstein buildings. And I was going to say, do you have any examples of where we had actual cooling challenges at some of our, you know, healthcare, long-term care facilities? So a couple of things to juggle there.
Yeah. It was definitely noted that staffing was a challenge throughout this period, and a number of different ways. One, family member, staff members chose to stay with vulnerable family members during some of this period. So they were choosing to do that. Anecdotally, I had lots of people say, I came into work because it was air conditioned. So, we did see some of that as well. Maybe flipping to the question around specific impacts, we had several long-term care facilities that we sent temporary air conditioning units to, that the alternative would have been evacuating those facilities. They were reaching dangerously high levels of heat, and were it not for the fast work of our team in sourcing, hey, we need people, and reaching out to vendors, and vendors being available to us on weekends, and really making an effort and a recognition that it was dangerous, and prioritizing health's requests, which is something I would highlight for those of you in emergency management, especially long-term care, because we recognize long-term care isn't quite as well. The facilities don't have the same levels that we do in acute. We have engineers, et cetera, in our acute world. That's not necessarily the case in long-term care. So ensuring you have a vendor that you could call in is something to consider, even for those of you who do already have air-conditioned facilities, as most of us do now, and as a result of funding requests that were received. If we had a power outage, that changes the landscape in game. Our acute sites have backup generators that manage those things. That's not true for long-term care. So our cousins in long-term care don't have those same levels of resourcing. So they're one of the ones that we consider to be one of the highest risks for us, and the area that we focus in on most. As a result of the 2021 heat dome, we co-funded a specialist position for long-term care in Fraser Health, and that specialist has been key in ensuring that there is greater awareness with our contract groups that we don't own and operate, but we work with closely, and of course downstream. If there's an impact there, it's going to impact the rest of the health system in our acute world and in other long-term care if we have to evacuate, et cetera.
Yeah, and I realized, so we're basically at time, but I think everybody is okay to stay on just for a few more minutes. There were a couple of questions in the chat, and I think one of these touched on sort of what I was mentioning as far as the actual health and safety considerations for the healthcare workers and the first responders dealing with extreme heat. So whether it's the actual high temperature exposure, or it mentions here even sort of the mental health impacts. I think I saw in some of the charts, the mental health was noted, but just kind of that care and consideration for our staff. Any comments?
Yeah, I'll start with Joshua. Great question around the alternate care. Yes, urgent primary care centers were being patient transfers were diverted to some of our urgent primary care centers so that they did not go directly into emerge for low acuity heat related illnesses. And that is something that we've strengthened since then, and have had discussions with, in particular, Vancouver community, where we're looking to have representatives from Vancouver community early in the emergency operations centers, so that they can literally be flagging that we will take patients, and they have the means to essentially surge if necessary. So some great work from our specialists with the Vancouver community in that particular area. With respect to healthcare workers, this was really stressed by our occupational health and safety group, as there were areas and conditions that were unsuitable for staff members to be working in. So it was an area that I believe WorkSafe BC also focused in on after this event to really ensure that there was a awareness of the expectations for temperatures in workplaces. And that has been something that we have discussed and shared in emergency operations centers since then, to ensure it's front of mind.
Okay, well, we've hammered through the questions. We're just at sort of time. Again, I want to thank you for all the work that you're doing. It was crazy to see things like referrals for AC units and all of these sorts of discussions that are taking place. I think it's a really good example to share across the country and to our international viewers of what you guys have learned from sort of the actions applied in BC is good to see. So I don't know if there's any final thoughts, Scott or Craig, before I turn it back to Francesco.
I'll let Craig go first.
I mean, I just had one. It was a chat comment earlier about whether we observed burns from hot pavement or playground equipment or cars or anything like that. And the answer from me, like officially, is no. But with those types of impacts, like I think media stories in Arizona and all that popularized those types of impacts. But epidemiologists, public health folks do rely on the media and journalists and the public posting about these impacts. They don't often rise up in these official monitoring and surveillance systems. It doesn't mean there's not an impact there. The same thing is with mental health impacts. They're just vastly kind of understood. And so, anyways, I just wanted to throw that in as a nod to like citizen science journalism, the importance of just gathering that anecdotal information in addition to all of the official stuff that we do gather. So just a final point from me.
Great, thank you for that, Craig. Really good point.
Maybe a last point, if I can. From our perspective, one of the things that I think is a key takeaway that we now plan to do in future is when we have a signal of an extreme heat emergency, we intend to have the kind of operational groups coming together in a more meaningful way so that we're able to monitor. The monitoring element is the thing that caught us off guard with 2021 because, based on 2009's experience, we didn't see this significant impact. But this was earlier in the year, and there were other factors that, like the extreme amount of heat associated with this, that we weren't prepared for and did not anticipate to expect. So that monitoring element of bringing together all of our streams of operations to be able to flag home health as seeing a surge in clients with dangerously hot homes. These are all indicators, and if we do that early preparedness work, if we're able to respond quickly in areas where something new is being flagged, we can prevent that downstream emergency department surge, for example. So there's real opportunity here in ensuring you have a strong network with all of the health system partners so that you have that awareness. It's often after the fact that we hear BCHS say, wow, that was very high volumes of calls. We don't see all of those come into the health authority because they didn't need to go to the emerge department. They were treated on site and then moved on. So I think bringing that group together and having that strong network of information sharing is one of the key takeaways that I have for our future events.
I think that's a great note to end the presentation on, which is we have to actually stay connected. We have to keep the conversation going. We have to share with one another. We cannot be insular on this topic because it doesn't recognize any boundaries, and the lessons can be easily applied and shared in other jurisdictions. So thank you so much for that. Francesco, close us off.
Thank you so much. Thank you, Misha. Thank you, Scott. Thank you, Craig. That was a great session. Thank you, of course, to our audience, as always, for taking the time to be here and asking questions and participating in the chat. Just a couple of quick reminders. This is being recorded and it will be live on our YouTube channel, which I have shared in the chat within the next few hours. And also, this is an ongoing monthly series, and we do have one session left this year. On the first Monday of November, which I believe is November 5th. So yeah, just if if that's of interest to you, if you know anyone that might still not have registered for the series but would be interested, please do share that. We do provide updates on our social media and our LinkedIn, which I have also shared in the chat. And with that, I would just like to give everybody one last big thank you for today's session. It was fantastic discussion and presentation. We really appreciate you joining us today. So thank you so much. And I hope you have a great day and the rest of your week.
Thanks so much.